Hello, everyone. We're just going to take a moment here to allow everyone to trickle in from the virtual waiting room. We're seeing all the participant numbers rolling in here. I hope you're all doing well today. I've had the great opportunity to enjoy the amazing snow we received the past couple of weeks and the sunshine today. So let's see, we'll give it another quick minute here and then we're going to go ahead and get started. So thank you all so much for joining us today. Welcome back for another session as part of the Gender Equity Education Series. I'm Jo Conant. I am a pathologist here at the UVM Medical Center and the Larner College of Medicine. I'm a member of the Gender Equity Steering Committee and the co-chair of the LCOM Gender Equity Education and Professional Development Working Group, which organizes educational sessions such as this one. So today I'm filling in for Dr. Ann Doherty, the Director for Gender Equity, who cannot join us. I'm excited to welcome you all back for this first spring session, where we will continue with the topic from our fall sessions and really provide a deeper dive into the context of gender and gender identity. So we've been really intentional about the Gender Equity Initiative to be more inclusive and recognize that this is not just a women's issue, to acknowledge that there are more than two genders and gender identities, and that it takes many voices in each and every one of us to create a safe working and learning environment for one another. So I think now more than ever, it's crucial that we be present and continue to advocate, especially for our transgender and non-binary patients, family members, friends, students, colleagues, and community members. So before I introduce our speaker, I do have a few housekeeping items to go through. First, this session has CME accreditation. If you'd like to claim the CMC, there's a QR code on the left to claim it. And then there's also a QR code to provide some feedback and provide an evaluation. The links will also be put into the chat if you'd rather not scan QR codes. We'll put the slide up at the end as well, and Olive will also send out links to the attendee list so you can complete those at a later time. As with most of our events, this session is being recorded and will be uploaded into the Gender Equity Education Series video library that will be available on the Gender Equity Initiative website. Next, disclosures, there are no financial interests to disclose. Live captioning will be available and the link will be put in the chat as well. And finally, we will have the QA function available for comments and questions. We don't have the chat set up, so feel free to use the Q&A function to provide questions and comments, and we will have try and save some time at the very end to do a few questions at the end. So with that, I am incredibly excited to introduce you all to Dr. Laura Erickson-Schroth. She and I first met, actually, I think it was the first day of college. We were in the same first year seminar together. And Laura, I'll say it's been really inspiring watching you from the sidelines and witness all the incredible advocacy work that you're doing for young people, in particular for transgender and non-binary mental health and well-being. So Dr. Laura Erickson-Schroth is the Chief Medical Officer for the JED Foundation and is a psychiatrist committed to improving mental health through education and resource creation. She provides guidance on how individuals, families, schools, communities, media, and other youth-serving organizations can take action to protect mental health and prevent suicide in teens and young adults, ensuring that all young people are served in data-informed and culturally responsive ways. Dr. Erickson-Schroth joined JED in 2022 after providing crisis intervention and mental health support to thousands of patients in over 10 emergency rooms in New York City. She's an associate professor of psychiatry at New York University. Much of her work and her career has focused on LGBTQ mental health, and she continues to see clients at Hetrick Martin Institute for LGBTQIA+ Youth. Dr. Erickson-Schroth is the editor of Trans Bodies, Trans Selves, a resource guide written by and for trans communities, now in its second edition. She's appeared on NPR's Fresh Air and On Point. She's a former board member of the Association of the LGBTQ+ Psychiatrists and of GLMA, Health Professionals Advancing LGBTQ Equality. Dr. Erickson-Schroth obtained her medical degree just down the road from us here at Dartmouth Medical School, completed a psychiatry residency at New York University, public psychiatry fellowship at Columbia University, and a consultation liaison psychiatry fellowship at Mount Sinai. And with you, I turn it over to you, Dr. Erickson-Schroth.
Hi, everybody. Good morning. I really just want to say it's such a pleasure to be here. And yes, Joe and I did meet in our freshman seminar, which I believe was called Drugs, Society, and Behavior. And it was, for me, an introduction to the field of psychology and learning about mental health. For the first time, I didn't have any psych classes in high school. And I fell right into it. And I keep in touch with our seminar professor, Carlos Velez, who we were just emailing with yesterday. And it's really so nice to see you. And I wore green for UVM Pride, and I'm really excited to be here with you all. I also have a number of colleagues working at UVM now because the pipeline between Middlebury and Dartmouth and UVM is, this triangle. And so hi to anybody who's on here, and it's really nice to see you. I'm going to pull up a PowerPoint, and I'm going to go a little bit back and forth between a PowerPoint and a couple of websites that I wanted to show you all. Bear with me because I have two screens here, and I'm hoping that everything's going to work correctly. So give me a second. Okay, are you all seeing the title slide?
We see your presenter mode.
Oh, that's not good. Let's see.
Go to the presenter view again, and there's a swap display on the upper left.
Yay.
See where it says swap displays? Try that.
Yep.
There you go. Perfect.
That work?
Yeah, thanks.
Right. So you all are seeing what you're supposed to see, and I'm seeing what I'm supposed to see. That's always good. All right. Well, thank you so much. I'm really excited to be here to talk with you about this topic. I think it's really pretty incredible what you all have put together. And I was saying this before we came on, but this Gender Equity in Medicine series is really just so amazing. And I haven't seen it at very many other places. And I've watched a lot of the parts of the other presentations that you've had and been really impressed. And so I'll talk a little bit in a minute about what I am and am not going to talk about today. But I think if you're looking for a good introduction to trans and non-binary identities, you just had a really great lecture in November by someone from the Pride Center of Vermont. So I'd encourage you to check that out. So I'm going to start off with disclosures and a couple of notes. The first is that I don't have any financial disclosures, so that's important to know. And then I also wanted to let you know a couple of other things. I'm connected with 3 different organizations that were listed on the first slide: the JED Foundation, Hetrick Martin Institute, and New York University. I just want to make sure you all know that I'm speaking for myself today and not speaking for any of the organizations that I work for. Also, I was involved in the development of the most recent WPATH standards of care, which you'll hear about a little bit. I was one of many, over 100 authors, but just in case you hear me talking about that, that was something that I was involved with. Another important note I'd make, which I just mentioned a little bit earlier, is that I'm not going to be going that much into sort of Trans 101 content today. I often in presentations cover things like names and pronouns and the basics of providing a welcoming environment for trans clients, things like that. Since we don't have a lot of time today, I wanted to dig in a little bit deeper. And so if you're looking for places to find that kind of information, I'm really happy to point you in the right direction. I do think the November lecture was really great. I'll also be talking about mostly adults today. So I won't be talking about teenagers under 18. I work primarily with young adults, so between 18 and 25. And just given the time constraints today, I thought I would focus on adults 18 and up. So if you're interested in learning more about younger teens, there are a lot of questions around trans teens these days, especially with all of everything that's going on. And again, I'm really happy to connect you with resources or anything else you might want to know. The last thing I'll mention is that I haven't attributed any of the photos, images in the presentation today. And that's, they all come from the same collection, which is called the Gender Spectrum Collection. It was a collaboration between Vice and a trans photographer named Zachary Drucker, and they're all available for free online with many other images for use by, primarily journalists, but also, including in presentations like this, just in case you're looking for something like that. Let's see. See if we can get things to move forward on this end. For some reason, let me see if my keyboard may not be responding. Does that work for you all? Can you see that? The agenda?
You're
We're
no
not
longer
seeing it
sharing
yet.
your screen.
No longer sharing. Okay. Sorry, I think my keyboard stopped working. Apologies. This is technology and well, we have to, let's see if that works.
We're good.
We're back in business. Okay.
We're back.
Okay. So this is the agenda for today. I always like to know in advance what I'm going to be hearing about in a lecture. So this is the plan. I'm going to spend a tiny bit of time talking about who I am. Mostly that's because, when I was a trainee, I really liked hearing about people's journeys. So I can tell you a little bit about mine. The content of the agenda today is somewhat skewed towards mental health providers. I'm a psychiatrist and I have a little more to say in that area, but I am going to be doing sort of basic, what does transition related medical care look like? What does transition related surgical care look like for anyone who's interested in those? This doesn't dig very deep into those. So if that's something that you want to know more about, again, happy to point you to the right places. Okay, so I thought I'd start off with a little bit about who I am. Again, I'm always curious when I go to talks about the speaker's background. This was especially true when I was a student and a resident. It really helped me to, sort of think about the pathways I might be interested in. When I graduated from college and started med school in the early 2000s, I was, part of queer clubs at my schools, but there wasn't really much public knowledge about trans identities. I didn't know very many trans people. I am personally probably something like what you might call non-binary, and there wasn't really a word for that at the time. A few of my friends were starting to discover that they were trans at a time when there weren't very many role models for that. I was also beginning to get exposure to trans health topics through med school, seeing what trans health looked like from the other side, and hearing about my friends' experiences as they were coming out, and also from the perspective of providers. And what I saw was there was this real gap in knowledge, where often patients at the time were ending up teaching their providers about their health or how to access hormone treatment, those kinds of things. And it was also a time when it was really hard to get accurate information about trans health topics in general. There were various websites, but not the kind of institutes and training programs that exist today. So one of the things I did was to seek out as much information as I could about trans health topics. In medical school, I did electives at Lyon Martin in San Francisco. I learned about primary care and about, hormone prescribing there. I flew out to Colorado and spent a month at Marcy Bowers Surgery Center there so I could, understand available surgical options and common concerns that came up with them. I also went to community rallies. I advocated for legislative changes to support trans communities. I got involved in advocacy in healthcare settings, pushing for better medical student training on LGBTQ health topics. And at the time, there really was a great community in the American Medical Student Association, AMSA, for advocacy in medicine. And it really gave me a place to explore my interests, to advocate for my patients, to really feel connected to other students. And then I worked together with hundreds of trans and non-binary people to create a resource guide, which was called Trans Bodies, Trans Selves. It was named after Our Bodies, Ourselves. And actually the Our Bodies, Ourselves team wrote the afterword for the book. They were very supportive and they understood what we were trying to do. It was sort of the same idea, they had created a guide in, the late 60s, early 70s, written by women, by cis women for other cis women, about all kinds of topics that were taboo to talk about at the time. It was a time when 80 or 90% of physicians were men, and women wanted to know about things like, sexual assault and abortion and lesbian identities and all these kinds of things that they weren't getting information about. And so that was the same idea with trans bodies, trans selves. So just gonna, show you, this is a cover of the second edition of Trans Bodies, Trans Selves, which came out in 2022. On the right is a primer that I wrote more recently with actually a therapist friend of mine who specializes in treating trans youth. And that one's great if you need the basics. So let's say you don't know that much about this topic and you're interested in, sort of a Q&A format, or you have someone in your life who you think would really benefit from a Gender 101 intro, hand it to them. Very easy. So in addition to doing that kind of work, writing, advocacy, I really got into as many electives as possible. Post-med school, in residency, I went to residency at NYU at Bellevue. I really wanted to learn more about trans health there too. So I worked at the HIV clinic at Bellevue. I did research rotations having to do with LGBTQ health. I co-led a group in Bellevue's program for survivors of torture that was made up of LGBTQ people who were seeking asylum. I was involved in helping to start the NYU Child Psychiatry Gender Clinic. And then after residency, I did a combined public psych and LGBTQ mental health fellowship, and then a CL fellowship at Sinai. And then I started working part-time at LGBTQ clinics, kind of around the city with my main job working in psychiatric emergency rooms. And I spent most of my career in psych ERs at Columbia in Washington Heights. So I've worked at a few different LGBTQ clinics around New York City. One is Callan Lord, which is New York City's biggest LGBTQ health center. It's an FQHC. Another is Apicha in Chinatown, which is originally called Asian Pacific Islander Community Health Association. And it was started in the 80s for AAPI people with HIV. And now it's grown to be a service provider for sort of anyone across the LGBTQ spectrum. And for the last 9 years, I've been part-time at Hedrick Martin Institute, which I call HMI, which is a drop-in center for LGBTQ young people 13 to 25. They can get food and clothing in connection to groups and counseling and psych services. And about 2.5 years ago, I switched from full-time clinical work, mostly in the emergency room, to the job that I have now as the Chief Medical Officer at the JED Foundation, which is not LGBTQ specific. It's a national nonprofit that protects emotional health and prevents suicide for teens and young adults. And the primary way we do that is by working with schools and community organizations to help them set up the systems, the policies, the practices that they need to sort of, set up their systems for success with young people. Let's see. Okay. So I think it would be really strange not to talk about the current moment, when we're talking about trans care. Just the number of executive orders released in the last 23 days. Now I think it's 30 days since I last talked about this. I actually thought I would take a minute to very quickly look at a couple of these in case anyone hasn't read the original documents. I actually think it's really important that we all look at the original documents. You hear a lot about this kind of stuff in the news, but I think you want to read the titles, you want to read the text yourselves. I encourage you to go find them yourselves and to read it. So I'm just going to pull up a couple and we'll see how tech-wise I can be. All right, so let's see. Okay, can everyone see that?
Yep,
This
you're
is
good.
great, great. This is straight off of whitehouse.gov. This is one of the executive orders that President Trump put out recently. It's called Protecting Children from Chemical and Surgical Mutilation, and it's an executive order to end any federal funding of clinics or hospitals that provide any sort of transition-related medical or surgical care to trans young people under 19. I won't, it's pretty hard to read the text of it. It's very sort of disparaging of trans people. Keeping men out of women's sports is another one. There's another one called Defending Women from Gender Ideology and Extremism and Restoring Biological Truth to the Government. These are real names. I didn't make this up. It's all on whitehouse.gov. The DEI one is called Ending Radical and Wasteful Government DEI Programs and Preferencing. There's one specifically about K through 12 schools, ending radical indoctrination in K through 12 schooling, which touches on race and gender. And then I don't know how many sort of researchers we have in the room, but the other one I wanted to show you was I frequently look at something called the Youth Risk Behavior Survey and a lot of other CDC websites. And of course, we all know that a couple of weeks ago, a lot of these websites were taken down. They were sort of working in the background to remove, particular information, a lot of it related to, the sort of sex versus gender conversations that the administration is, talking about. And now, instead of having them taken down, this is the message that you get. It says, per court order, we need to include this message. Any information on this page promoting gender ideology is extremely inaccurate and disconnected from the immutable biological reality that there are two sexes. It goes on to say the administration rejects what they're calling gender ideology. This is, interestingly, the Youth Risk Behavior Survey, which I don't know, if everyone on the webinar knows what this is. This is not trans related. It's not LGBTQ related. This is a national survey of young people in high school that asks about their lives, things like health related things, violence in their homes, drug and alcohol use, mental health symptoms. And it's a really important source of data for a lot of people to learn about what's going on with high school students. There are sections where they divide, answers, and they show disparities between different groups of young people, including LGBTQ youth and including trans youth. And so it's one of the many websites right now that has this, this little addition to it. Okay, I'm going to take us back, hopefully. Let's see. Okay, are you seeing what you're supposed to see?
Swap
Should I
displays.
swap? Great.
Yep.
Okay, wonderful. Okay, so again, I think it's really strange to sort of see all this going on right now and to not talk about it in our, medicine is a field that interacts quite a bit with people in the world and what they're experiencing. We have a lot of things that we're seeing in these executive orders that are really going to affect people. One of those is this idea of two sexes, that says basically the federal government recognizes only two sexes that they consider non-changeable. This will apply to ID documents like passports. Federal agencies are now not allowed to ask about gender identity on forms or anywhere else. This is going to affect data availability. Again, I talked about the CDC websites being down, important data sets and information not being available or having information removed. This and other things are going to affect research funding, apart from freezing of federal grants. The administration has plans to significantly decrease NIH funding for biomedical research. Any grants that involve DEI subjects have been terminated. Researchers aren't able to access previously approved funding. the DEI executive order is ending any programs and immediately firing anyone who works in any way on diversity, equity, or inclusion. Encouraging employees. What they're doing right now is encouraging employees to turn anyone in who does this kind of work. The ones on schools, there'll be no federal funding for K through 12 schools that acknowledge trans identities or provide affirmation for trans young people, or, talk about systemic racism. In athletics, trans girls and young women are going to be barred from playing sports. That includes elementary and middle school children. We're not just talking about college athletes. In the military, the executive order sets up the government to reject trans people from participating in the military and to deny current military service members access to gender affirming care. They have TRICARE, and so there are specific stipulations, and they have to use that kind of insurance to get care. The one on trans youth care says, again, that institutions that receive federal research or education grants can't provide gender affirming care for young people under 19. So taken together, I think there's so much very real and reasonable community fear. I can't tell you about the number of people that I've heard from who are afraid for their lives. They're wondering what the next steps are going to be. Friends who are afraid to fly, not just because of all of the aviation issues going on recently, but because they're afraid the TSA is going to single them out even more than they have in the past. Colleagues who are talking about taking down mentions of their work if it has to do with LGBTQ health, because they're afraid of being targeted or being doxxed. Parents of trans teens who've been calling me, who don't know where to turn for care as clinics are being shuttered. Adult trans friends of mine and colleagues who are worried about their access to gender affirming care because they believe they may be next. And I don't think they're wrong. At least 8 states ban Medicaid coverage of adult gender affirming care. There are a few states that have made it very difficult to access as adults. Florida and Missouri are 2 of those. Sometimes requiring patients to see many different providers or requiring in-person visits, despite there being few places in those states to see providers. Most recently, Ohio drafted regulations that would require trans adults to get approval from an endocrinologist, a psychiatrist, and a bioethicist before accessing hormones. These are adults. So in addition to the effects on healthcare, I think many trans people are feeling, vulnerable and scared. If the federal government can in public and openly talk about this kind of action against them, they feel like it signals that it's okay, and it opens them up to harassment and violence. We're seeing the Justice Department is not following up on, complaints, that people are putting in. So, it's all, I think, very scary. So I'm not going to spend a lot of time on it, but I think it's important to acknowledge the history of psychiatry and of the medical field in general in trans communities. I think a lot of what I'm going to say here applies to other areas of medicine, but psychiatry, I think, has had this outsized role. And I think it's important to discuss it. So, in terms of pathologization, it's interesting to think about how far we've come in our field. And I think also how far we have to go. So until 1973, homosexuality was still in the DSM. It was only removed thanks to actually brave psychiatrists and other activists outside of medicine who are willing to, risk their lives and their careers to speak out at a time that they could have been fired from their jobs. There was a famous lecture at the 1972, I believe, American Psychiatric Association meeting where a gay psychiatrist came to the meeting to be on a panel, but he was dressed in an oversized suit. He had on a Nixon mask, and he was using a voice changing machine so that he wouldn't be recognized, because he thought that if he was on this panel arguing that gay people shouldn't be pathologized, he could lose his job. And it was okay for him to be fired at that time if his employers found out that he was gay. So it really did come out of a lot of activism from gay communities. And trans communities have similarly been pathologized and continue to be today. So the DSM category, gender dysphoria, which exists in the DSM-5, makes it a mental health condition to experience distress related to having a trans identity. And this is in a society that actually makes it very hard for trans people to not experience this kind of distress. So that sends a signal from a really important medical institution, the APA, that there's something wrong with being trans. And it really drives a wedge between trans communities and mental health providers, and it really decreases trust. And it makes people less likely to seek out help. And the same is true, I think, for the larger medical community. Trans people have been treated as oddities or special cases, as people whose lives are, pathology. So there's something in the trans community called trans broken arm syndrome. And I don't know, if anyone here has heard of that, but it's the idea that, you could go into the ER with something completely unrelated to your gender, something like a broken arm, and the provider will immediately assume that whatever problem it is, it must be related to your gender. And then even if they realize that there's no connection at some point, somehow they'll still ask you questions about your identity that are totally irrelevant to whatever's going on. And of course, there are important questions to ask, at times. For example, if you're coming in with abdominal pain, as a provider, you do need to ask the person about, their genitals and their internal, organs. But if you come in with a broken arm, probably not. So pathologization is something that trans people, often have on their minds when they interact with mental health providers. In terms of gatekeeping, so psychiatrists and other mental health providers are, sometimes purposefully at times, but a lot of times not of their own accord, acting as gatekeepers for trans people to accessing healthcare and other, necessities. For a long time, trans people had to perform a particular type of lifestyle in order for psychiatrists to grant them access to care. They had to pretend that they were stereotypical gender-wise. So trans women had to sort of profess a love for anything feminine, say that they had always known that they were girls, since growing up. They had to be straight in relation to their gender identity. So trans women had to be attracted to men and trans men had to be attracted to women. And people were denied access to care if they didn't fit into these models. And there's lots of information, letters, journals, diaries, where people admit to lying because they know from friends who have told the truth that this was not going to get them the care that they needed. So even now, for the most well-meaning providers, when we stand between someone and their access to medical care, when we make decisions about their life for them, including things like hormones and surgeries, but, also the ability to change their identity documents or other legal issues, we're setting up this opposition to each other. And we're in a position to judge someone else rather than to support them, which is what we're all actually here to do, right? So that's what I'll say about gatekeeping. Selection bias. So I wanted to take a minute to talk about this term that's actually, many of us have heard this from research. If you took, Joe and I might have taken the same, psych stats courses or research methods. It's typically used in research, but I like to use it sort of when I think about clinical care. I worked in psychiatric emergency rooms for a number of years. I saw the reactions that staff had to trans patients coming into the ER. A lot of the time, they perceived trans patients, specifically in certain ways. They had beliefs about, trans people having significant mental health issues. I realized at one point what was happening, and that was that many of the providers had never met a trans person in their lives outside of working in a healthcare setting. It's the equivalent of never meeting a man outside of the emergency room and then assuming that all men are like the men who show up in an emergency room. And I'm talking about a psychiatric emergency room. So if you assume that all men in the world were like the men that show up in a psychiatric emergency room, wouldn't be a great assumption. So, they just didn't have a rich understanding of what, many of us do who have friends and colleagues in trans communities. There are trans people everywhere living everyday lives with families and jobs. And, so I call this selection bias because by virtue of many of us coming into contact with trans communities only at work, we select out a group of people and we make assumptions about everyone in that group based on the people that we see coming in for care. And that's especially true in mental health. The last thing I have on here is we're just like everyone else, and I add in this part just to say that as mental health providers, we're not separate from the society we live in. And as medical providers, that's also true, right? All of us approach with many of the same, ideas and understanding of situations. We have a lot of the same prejudices as everyone else. It would be really hard not to. We live in the same world as everyone else that we're around. And that means that as providers, we can do real harm to people. And not just trans people. I've seen providers make racist comments, sexist comments. I've seen psychiatrists use the wrong pronouns for patients purposefully, knowing, that isn't the pronoun that they use. And especially in acute settings, people are often coming to us and they're seeing us on one of the worst days of their lives. If someone's coming in an emergency, or if someone's coming in, for an important procedure or surgery, they're scared and we're all sort of, they have to trust us. And to have that kind of experience, it's really unbelievable that happens, but to have that kind of experience actually is really scary and it puts them at risk of being targeted. I've worked in emergency rooms for a long time and seen trans patients who were outed by providers sitting in a cot right next to someone who could then target them for hearing that. So, it's really, really scary. And there are studies that show, that trans people often avoid needed medical care. And when they're asked why they're avoiding care, they say they're afraid providers, won't understand them. They'll judge them or they'll treat them badly. They report being yelled at, being called names, sometimes even being physically assaulted in medical settings. So in those kind of situations, we're not the healers, we're making things worse. But again, that's because we're just like everyone else. We live in this society. And so if we can recognize how living in this society can affect our work, I think we can do a lot better. Okay, so this is the part where I'm going to talk a tiny bit about transition-related medical and surgical care. I find that many lectures don't cover these topics. A lot of lectures are sort of Trans 101, pronouns and names and things like that, creating a welcoming environment, which are all very important. But this is the kind of thing that I think isn't typically covered. So settings, what I mean by settings is talking a little bit about where trans people have gotten transition-related medical and surgical care. So historically, when centers started opening in the United States, it was through university medical centers. So they're initially, in the mid 20th century, there were university medical centers that were starting to open up transition-related care clinics. There was a big shuttering of those in the late 70s into the 80s, starting with Johns Hopkins, and then sort of all of the other ones shuttered as well. And that was when community centers really came in to fill in the gap, community health centers. There are still some university centers that require letters from psychiatry or endocrinology in order for someone to start hormones. But now mostly hormone-related medical care is delivered, by primary care providers, by family physicians, internal medicine, nurse practitioners. The Endocrine Society has really great guidelines on prescribing hormones. It's not very difficult. And still access to care really varies significantly. So there are some states where, it's much harder to find someone willing to prescribe, even though this is something that can be done, through primary care. In terms of medications, the basics, Trans men typically take testosterone, and usually that's injected. Sometimes it's transdermal, like an androgel. In terms of effects, early effects, often things like acne, which not everyone loves. Menses usually stops between 1 and 2 cycles. Sometimes increased libido kind of right away. And then as you get into the 6 months to a year range, facial hair, voice dropping, which is permanent. And actually, some people can get male pattern baldness. So that's an important thing to talk about with your clients, making sure that they know that that can happen if that's a pattern in their family. Many trans men are able to become pregnant even after they've taken testosterone, if they stop testosterone and they want to become pregnant. If they are taking testosterone and they're sexually active with cis men or with anyone who has a penis, you want to talk to them about using birth control. Because you really don't want to become pregnant on testosterone because it's harmful to the fetus. In terms of trans women typically take estrogen and then in the US, spironolactone. So, estrogen comes in lots of different forms, oral patch, there's injectable, spironolactone, typically oral. Sometimes they'll also add progesterone, though not as often. And in terms of estrogen, the kind of, changes you're going to see often initially sort of decreased libido, some increased breast growth, decreased muscle mass. And people who are taking trans feminine hormones should also be counseled about, reproductive potential effects. It's common for trans women to have decreased fertility or to be unable to produce viable sperm after being on these kind of medications. I think you really have to talk about taking an individual approach. People will want to take different medications at different levels, especially for non-binary folks, but also for some other people that might prefer to take lower doses, might want to appear more androgynous. It's important to talk with clients about the fact that you really don't have a lot of control over what these medications do. So, you might, ideally want, your voice to drop, but not start having more facial hair, but you can't really control, exactly what's going to happen. In terms of monitoring for testosterone, mostly you're monitoring the effects of testosterone. Cisgender men have a really wide range of testosterone levels. And so you're looking for the effects. You also want to be following LFTs, hemoglobin, lipids, A1C, because those can be affected. In terms of estrogen, you do often follow testosterone levels. So while someone's on estrogen and spironolactone, which I didn't mention, but it's an androgen blocker. People may remember from medical school, one of the side effects, something that's considered a side effect of spironolactone is gynecomastia. So that's the reason people are on spironolactone. So with estrogen and spironolactone, you're measuring, testosterone levels typically to see if they're suppressed. You're getting LFTs on estrogen, you're getting prolactin levels on estrogen because it can increase prolactin. On spironolactone, it's a potassium sparing diuretic, so you're getting potassium levels. And then for any mental health providers who are on the webinar, there are not very many interactions between hormones that people take for transition and psychiatric medications. The two that I've run into, one is estrogen with Lamictal. So the neurologists will know this too. You often see this with your pregnant patients, that as their estrogen levels start to go up, you have to really increase the Lamictal doses to get to the same levels. With spironolactone, there's an interaction with lithium. That's important to pay attention to. It can increase lithium levels, and that actually can be dangerous, right? So you can get lithium toxicity. So you really want to think about how important it is for someone to be on lithium if they're also going to be on spironolactone. And what I wanted to mention here with quality of life is that there have been many studies that have shown increased quality of life for trans people who want to take hormones and are able to get them and to access them. And it really shows how important it is. see. Okay, transition-related surgical care. I'm also going to do sort of a, a brief introduction to this. So, one important thing to say is that not everyone is interested, in surgeries. That doesn't make them any less trans. People have many reasons for not having surgeries. They could be anything from, not wanting to undergo surgery in general of any kind. Some people have concerns about sexual function, though sexual function for the most part is maintained. And then actually for a lot of people, cost is the issue. Insurance a lot of the time won't pay for transition related surgeries, and a lot of people can't afford them. You may see GoFundMe's, for trans people trying to be able to access surgeries. In terms of types of surgeries, the most common type of surgery is top surgery. That's trans men or non-binary folks often getting top surgery to have a masculinized chest. Trans women getting breast implants, for example. Also common for trans women, orchiectomy, removal of the testicles. It helps to bring down testosterone levels and is a less expensive surgery. Many trans women also are interested in facial feminization surgeries. This could include things like a tracheal shave or, other sort of cheek implants, things like that, to change the appearance of their face. And actually, many people prioritize that kind of surgery because they're thinking about their ability to kind of live their lives without being noticed, harassed, those kind of things. And then some people do undergo genital surgeries. So typically for trans women, that would be a vaginoplasty, the creation of a vagina. For trans men, that would be a hysterectomy, metoidoplasty, which is the extension of the clitoral ligament, or a phalloplasty, which is the creation of a penis, which is a multi-step procedure typically. And then again, with quality of life, like with hormones, there's a lot of evidence that quality of life improves with surgical intervention for those people who want it. In terms of surgical satisfaction, there are sometimes, of course, people who aren't satisfied with surgical outcomes. Typically, this has to do with things like appearance or scars or function. It's not usually related to regret, in terms of gender identity. Most people who are undergoing transition-related surgeries have had a lot of time to think about it. There were a lot of other things that they did, leading up to that in their lives. They saved money. They made sure they could take time off from work, that they could have, friends or family there to help care for them. So it takes a long time to get there. And then it takes a long time to even get a consult to then talk to a surgeon to then, schedule a surgery that might be, a year out. So people have had a lot of time to think about it. One question that I'll add in is that, a lot of times people ask me about sexual function, and typically for genital surgery, you are able to preserve sexual function. That's not true 100% for everyone across the board, but, it is something that should be expected for most genital surgeries. So I'll just try to do this relatively briefly because I know we're getting, short on time. I wanted to talk a little bit about common mental health concerns. There are many, many studies that show increased levels of trauma in trans communities, harassment, discrimination, violence, especially towards trans people of color. If you look at the HRC Foundation report that looks at homicides of trans people over the last year, 50% were from one group only, and that's Black trans women. So we're talking about a lot of sort of intersections. I was involved in a number of different studies that looked at trans people either in different clinics or programs or emergency rooms. And all of the studies showed significantly higher rates of physical sexual abuse in childhood and growing up, from people in their communities, family members, often in response to people's, gender presentations. Trans communities have higher rates of homelessness, unemployment, incarceration. And, those kind of experiences lead people to have, elevated rates of depression, anxiety, PTSD, substance misuse, suicidality. Importantly, trans people appear to have very similar and not elevated rates of conditions that we think are more biologically based. So things like bipolar disorder, schizophrenia, seem to have the same rates as other populations. And what that means, of course, is that, most of the conditions that trans people deal with are, very similar to other conditions that we deal with all the time. But that also means that there are some trans people who do experience mania or psychosis. And they might be in kind of dangerous, situations because they have less autonomy than other people. And it's important to point out that people who are trans who do have psychosis or do have, experience mania can still make choices for themselves about their transition related care. Those decisions just have to be made, when they're not actively experiencing, symptoms that might prevent them from making those decisions. I get a lot of questions about hormones and mental health, related concerns. If you're in an acute setting and someone comes in on hormones and you're wondering if maybe the hormones are contributing to psychosis or mania or something like that, the answer is almost 100% of the time no. There's no evidence that transition-related hormones at prescribed doses can contribute to mania or psychosis. So if someone's coming in, you want to keep them on their hormones, even if they're experiencing mania or psychosis. And there's a lot of evidence that people's, again, quality of life, depression, anxiety, body dissatisfaction, overall psychological well-being improves on hormones. I'm not going to probably go through every single one of these in detail, but I just want to, briefly say when someone's coming into a mental health setting, and this is true for medical settings too, it's important not to assume that they want to or don't want to talk about their gender. I think a lot of times providers assume that someone wants to talk about their gender. It may be something that they, have spent a lot of time talking about with another therapist or another provider, and they don't really, that's not what's on their mind right now. Be really curious with people and don't assume anything about them. It may take a little bit more time to build rapport sometimes. It's hard when, you've been through a lot of trauma to build healthy relationships. And so I would say give it time and make sure that because that trans communities have had these difficult interactions with the medical field, that you're paying attention to that and you're showing up and demonstrating that you're there and that you care, and reflect on your role and how, being a provider who might be in the role of gatekeeper could appear to someone. I'm not going to go into detail about this. This is my last 1 or 2 slides. For anyone who wants to know about writing letters for gender affirming surgeries, to me and to colleagues across the country, this is a capacity evaluation. We all know how to do those. It's pretty straightforward and simple. You're not making a decision about this person's gender identity. You don't have to write in your letter, this person is transgender. You have to write that they have capacity to make this decision, and they're making this decision as an adult with capacity. And a lot of providers worry about liability. What if someone's upset later about their medical care? If you've documented that you went through a capacity evaluation with them, you should be covered. This is my last slide. If you want to learn more, these are places you can learn. WPATH, GLAMA, Fenway, they all have really good sort of educational training programs. If you want to get involved, start providing transition-related medical care. If you're someone who could be a hormone prescriber, why not? Be available for people. Right now, it's really important to do things like asylum evaluations. There are people that really need, a safe place to be. Again, if you're a mental health provider, happy to help you learn how to write surgery letters and advocate. And then finally, I put on here kindness, because I think we could all use a little kindness right now. And all of our communities could. So thank you. And I'll turn to the Q&A, and then I'll actually put up this last slide so that you have my contact information if you want to find me.
Awesome. Thank you so much, Laura, for spending this hour with us. And I think really helping to share your knowledge and wisdom. I think this is a really, as you say, a very timely session in terms of, we certainly appreciate that the summary in terms of the current landscape and the flurry of executive orders that are coming out, right? And impacting directly our trans and gender minority community members. We have a couple of questions here, and I think we're only going to have time for one. But, you mentioned early on that many folks are currently living in fear. And I think additionally, there may be a sense of feeling of like futility or hopelessness right now as well, with just the flurry and the number of executive orders and changes that are coming out that are having a significant impact on people's lives. Um, what can we do to help and provide some hope and some actionable things that we can do to provide the meaning and the purpose right now, both for one another ourselves, but one another and specifically to protect our trans and queer community members?
Yeah, I think that's a really hard one. I go back and forth every day myself. I think about, I think there are small things that we can do that add up that really matter. Again, things like providing care, every single person that you provide care for in a kind way where they're getting something that they need, that they don't have to drive 6 hours for. That really means something. Any small things you can do around, if you're seeing in your clinic or your medical center that there are things that are missing that are important, like, do we ask people about, their identities in the clinic where we work? Do we teach the students that we're working with or the trainees about these important topics? They might seem small, but I think they are really impactful. And during this kind of time, I like to think about, there actually is a really large community of people that care really deeply about you and about communities and all, these kinds of things. And we can't let, sort of rhetoric that's coming out of Washington, affect the really important work and the community building that we're doing.
It's a great message of hope. Community, right? Connection and community right now. So,
And what you all are creating here, I think, is one, example of that.
thank you. Unfortunately, we're not going to be able to get to any other questions at this point, but I think we're going to try and log any that are here that are unanswered. And Laura, if we can pass those along to you to be able to get some responses, that would be great. So I just want to say thank you to every single one of you that are here, that is attending this session, and for being here today. Before we drop off, I just want to remind you and remind everyone that March 6th is our celebration of gender equity in medicine and science. Charity Clark, Vermont's current Attorney General, and the state's first woman ever elected as Attorney General of Vermont, will be our keynote speaker for that session. And she will be talking about leadership and leading as a woman in the 21st century. I think she would be really inspiring and really great. So I hope you can join us for that. There will also be an award ceremony acknowledging all the hard work that you are all doing. So please join us, and it's always a great event. Looking forward to that. Thank you again, Laura, for being with us and for sharing your knowledge, and for all of you for participating today. And we'll see you in March at the celebration. Thank you. Take care.